Our next speaker is Dr. Miriam Sklerov. I'll read it and then talk a little bit personally as well. Dr. Sklerov is a movement disorder specialty neurologist at UNC, University of North Carolina, School of Medicine. She completed medical school at New York Medical College and her neurology residency training at Columbia University Medical Center in New York City. She then completed an extended 3-year fellowship training. I don't know how you doctors get all these degrees and all this school, but I think it's because they're really smart. Got to be the answer. Smart and good looking both. During her fellowship training, Dr. Sklerov obtained her MS in epidemiology from the Mailman School of Public Health at Columbia. She joined the UNC Neurology Movement Disorder team in August 2017 as an assistant professor. She is dedicated to educating healthcare providers, patients, and the general public about MSA, PSP, and corticobasal syndrome and promoting research in these conditions. Please welcome Dr. Sklerov.
Hi, thank you so much for that introduction. Thank you all for being here today. I'm so excited to see a lot of familiar faces and soon-to-be familiar faces. So I will do my spiel, and then I really want to have people ask questions at the end, okay? There is quite a bit of overlap for some of the things that I'll be talking about with Dr. Golby, but hopefully I won't be boring you at all with all the repetitiveness. So, okay, so today what I wanted to talk to you about, this is my outline. Which doctor should I see? This is often a question I get, should I be seeing you? Should I be seeing my general neurologist? And then we're going to talk about the first visit. How do you prepare for the first visit? What do we expect to talk about at the first visit? How can I get the most out of it? Then we will go into a little bit into the symptoms and the treatments, even though we did just get a great talk about it with Dr. Golby, and there is a handout that I provided to talk about some of those things too. And then how do I just get the most out of my appointments given the information that I have now? Okay, so let's get started. Which doctor should I see? The first doctor that most of you will see, the first person, the first line warrior, is going to be your primary care doctor. The first symptom that comes on, before this all happened, how many of you had heard of PSP or MSA or CBD? So the first symptom, falls, vision problems, voice changes, that's all going to come to your primary care doctor. And your primary care doctor plays an extremely important role. This person, even once you start seeing other specialists, when you get referred, all those things, this is the person who is coordinating your care. This is the person who is going to hear about those symptoms when they first crop up. This is the person who needs to make sure that those referrals went in, that all the doctors are talking to each other, that it's all getting done for you. So I always insist that my patients see a primary care doctor regularly. This is going to be the person you see the most. This is not necessarily the person who is going to be the most comfortable dealing with the ins and outs of treating these conditions. So most likely, you will get referred at some point to a general neurologist. A general neurologist, some general neurologists actually have a lot of knowledge about these conditions and will feel very comfortable, prescribing medications and treatments. However, a lot of general neurologists will probably recognize at some point that they need some more input from someone who maybe sees more of this, and they will refer you to usually a movement disorder specialist, sometimes a cognitive neurologist or behavioral neurologist. A movement disorder specialist is a neurologist who just has a little bit extra training in Parkinsonism, Parkinson's disease, atypical Parkinsonisms, dystonia, ataxia. In some areas of the country, there's a lot of movement disorder specialists, no problem. In some areas, you may be driving a couple hours to see one. So what I tell people is, if you have MSA, PSP, CBD, it is in your best interest to see a movement disorder specialist at least once. And then moving forward, depending on your relationship with that doctor, your relationship with your other doctors, and how convenient it is, how easy is it to actually see this person. That's how you decide how often you will be seeing that doctor. Will it be once a year? Will it be every few months? That is a very individual decision. Okay, now let's talk about the first visit. How do I prepare for the first visit? What is it that the doctor needs from me to really understand what's going on, and how do I impress upon the doctor what I need to feel better, to do better, okay? So the first, sometime in the first, visit, the doctor will try to get this information from you. When did my symptoms start? When did this all begin? How long has this been going on? And sometimes a better way of thinking about it is, well, when was the last time things were totally normal? And this definitely helps us get a frame of mind, understand, okay, this has been going on for this many years. I kind of would expect this to maybe start to creep up. Maybe I'm going to ask about these other things. What were the first symptoms? Was it a balance problem? Were you falling? Were you having vision problems? Was it speech changes? And then have the symptoms changed? Have they progressed? Are there new symptoms? Are the old symptoms the same but just worse? Are they affecting more parts of the body? Are they happening more frequently? And what is happening to me now? What am I feeling? What are the symptoms that I have now? And this part is key. Dr. Golby mentioned that in 30 minutes, how are we going to talk about all these things? How are we going to get to every symptom that I could be experiencing, given how the huge breadth of things that could be affected? Well, it's really a good idea to pick out the couple things that are really impacting you the most. What is it that is making it hard for you to function in your daily life? What is impairing your ability to do the things that you want to do today? Okay, so other questions that we'll want to know the answers to: what diagnostic testing have I already had? If you've had prior blood tests, if you had a spinal tap, if you had a brain MRI, make sure that you bring those to the appointment if you can, or get them to us ahead of time. We always like to see the images. If you've had a brain MRI, the report is okay, but we really want to see it. What treatments have been tried? It's helpful for us to know not just the names of the medications, but what dose did you try? How high did it get? In some cases, we might decide, well, yes, you tried that medication, you're saying it didn't work, but you were tried on such a small dose that I think maybe we could try a little higher. We will ask you about your other medical problems, because that'll come in handy when we're deciding how to treat you. What surgeries and hospitalizations you've had is also part of that. I cannot stress enough a concise and up-to-date medical list. I can't even tell you how many times people come in, they say, oh, well, I just saw my doctor here last week. You should have the medication list in the chart. Believe it or not, a lot of times it's accurate, but a lot of times there's something different, something's changed, something wasn't recorded right for some reason. So always bring that up-to-date medical list. I usually tell people, if you have a list that you keep at home, take a photo of it on your phone. It'll always be on your phone. When you get a new list, take a new photo, delete the old one, keep it up to date. And then we'll ask about family history. Is there anyone in the family that's had similar symptoms or any neurologic symptoms? And then, of course, write it down. It is so easy to walk into the appointment, you're nervous, you had trouble parking, you're worried you're going to get towed, you have to think about, whoa, when I get home I have to do all these things. You're not going to remember all those things that we just talked about, all the important things you wanted to make sure you were going to tell your doctor. So please write it down. What do you bring? What do I bring to the visit? Your notes, right? You just spent all that time making those notes. Again, maybe snap a photo of them on your phone if you're not sure that you might misplace the paper. Find ways to try to remember to bring it as much as possible. Bring someone with you. Showing up to an appointment alone is tough. It's hard to remember all the things you wanted to say. It's hard to remember what the doctor's going to be telling you. Having someone else to sit and help process the information is really big. When you go home that night and you want to sort of debrief in your mind, it's really helpful to have that person with you, and you guys can talk about it and remind each other what actually happened that day. Medical records, of course, I already mentioned this. And again, if you have the images, bring the images. If you use a cane or a walker at home, please bring it to the appointment. A lot of times people think, well, when I go out, it's just much easier for me to go in the wheelchair. But yes, at home I walk with a walker. I want to see how you walk with the walker at the appointment. So please bring it. Please bring it. And then, of course, water and snacks. We don't want people getting dehydrated or hypoglycemic in the waiting room. Okay, so symptoms and their treatments. We did talk a little bit about this already with Dr. Golby. I want to, again, stress that because of various factors, a lot of the treatments that we use in these conditions have not actually been tested for these conditions. They've been tested in similar conditions. They've been tested in not so similar conditions. There are a few that have been tested specifically for these conditions, and we'll talk about that more this afternoon. But a lot of the treatments that we neurologists use for our patients are, at best, anecdotal, or again, we see that it works for the same symptom in a different condition. So keep that in mind. So you guys have that handout, I hope. So I'm not going to spend a whole lot of time on this so that we have time for questions. But I will go over a few of the symptoms and hopefully, again, not repeating too much of what Dr. Golby already said. Parkinsonism, slowness, stiffness, small movements, tremor for some people, and the big one, the postural instability, meaning the tendency to fall backwards, particular. That's very specific. The medication, so in the handout, I actually broke it up into non-medical therapies as well as medical therapies. We cannot stress the importance of physical therapy, occupational therapy, and speech therapy, as well as pelvic therapy, but that's not for this symptom. I cannot stress that enough. And probably the most literature for motor symptoms has been in those areas, the physiotherapy areas. But the medical treatments we use are typically the ones that, for Parkinsonism, the ones that we use for Parkinson's disease. In addition to helping with the stiffness, that seems to be one that can respond quite well to the medications in some people. I have seen a reduction in that falling backwards. So people can actually have some reduction in their falls frequency, which is a big deal, which is why I always recommend we try a Parkinson's medication. And we try to push it up as far as we can, unless, of course, we run into side effects. Dystonia is another motor symptom, quite common. The dystonia is abnormal muscle contractions that cause either an uncontrolled posture or sometimes an abnormal movement. The most common types of dystonia that we run into are in the neck. That's a very common one. Either the neck is pulled forward, the neck can be twisted, it can also be pulled backwards. Another common dystonia that we see is in the hands, fisting, the arm turning in or twisting. We can also see in the foot, the ankle turning in, the toes curling down. Those are probably the most common dystonias that we will run into. And again, physical therapy is helpful and occupational therapy is very helpful, but the gold standard treatment for this is Botox injections, as Dr. Golby mentioned. And we do have some oral drugs that we use. We generally stay away from those for side effect reasons. And then ataxia. We see ataxia in MSA, we see ataxia in PSP, and the best evidence right now for the treatment is mostly physical therapy, occupational therapy. There are a number of drugs that have been tested in all types of cerebellar ataxia, not specific to these conditions, and I do tend to try those with my patients to see if any of them provide benefit, which they can in some cases. CoQ10 is actually one of those that I use for this indication as well. Then we have the non-motor symptoms, meaning not having to do with movement, but definitely other symptoms that can severely, in some cases, affect quality of life, affect ability to function. I didn't put all of them on here. There's more in your handout. This is not comprehensive. There may be many symptoms that you experience that you will not see listed, and I'm happy to talk about those if you have questions. But I also, on the flip side, I want to stress that there will be a lot of symptoms that you see on here that you will never experience, okay? So again, there are non-medical interventions that we use for these, as well as medical interventions. The first step for treating a lot of these problems, the blood pressure drops, the confusion, is to review your medical list. What medications are you taking that could be causing this, that could be making this worse? That's usually the very first step that we want to take when we're talking to you about some of these symptoms that you're experiencing. And then for the orthostatic hypotension, again, some of the conservative measures, the drinking enough water, which can also help some of these other symptoms, the urine symptoms, the constipation. Are you, having enough salt in your diet? Things like that can actually help so much that we can actually avoid using some of these medications, which is always my goal. Cognitive symptoms, again, we do have medications for that if we need to. Speech therapy and cognitive therapy are also extremely useful. The constipation, again, we start with the conservative measures. Drink enough water. Is there fiber in your diet? Are you eating fruits and vegetables? Kind of more common sense things that we don't think of necessarily right away. And for the drooling, actually, it can be a big problem for some people as well. And I prefer using Botox for that because the other medications can make people a little bit loopy. And sleep problems, Dr. Golby had talked about some of the different sleep problems. There is a multitude of sleep problems that people can encounter. Some of it is simply just waking up a lot at night and then having trouble getting back to sleep. And that can be just the brain waking up. That could also be having to run to the bathroom. But in addition, there's other things. There's abnormal limb movements of sleep, kicking, jerking. There's acting out dreams, the REM sleep behavior disorder. There are breathing problems that people can have in sleep, particularly the sleep apnea that we had mentioned. So for that reason, I often will recommend sleep studies for my patients, even when they're telling me, I think I sleep okay, I'm not really noticing any problems, but I'm pretty sleepy during the day. I'm tired a lot of the time. So that could also be a trigger for me to say, you know what, let's take a closer look at your sleep. Mood problems, anxiety, depression, and apathy, not really having this, not caring as much as you used to about the things that used to get you more riled up. We have treatments for those things. Swallowing is a fairly common problem. So we do recommend fairly regular swallowing evaluations, both with a speech therapist, and as well as a more objective measure like a modified barium swallow or a FEES, which is actually when the ENT doctor takes a look at your vocal cords while you're swallowing. Vision problems, there's a multitude of vision problems that we can encounter. I usually do enlist the help of my ophthalmology colleagues or neuro-ophthalmology colleagues. And low energy, I heard some people asking about that. So that's a big problem can be a big problem for people. Again, trying to understand what's causing it is usually the first step. Is it a sleep problem? Are you just not getting very good sleep? Is it because your blood pressure is low and we didn't really put it together because you're not dizzy, for example? Okay. So, putting it all together, how do I get the most out of my appointment? When I go see my doctor, how do I make sure I walk out having learned something, having gotten something from the visit? It's not just a waste of time, or I leave and think, well, we didn't really address what was really interfering with my life. So again, how to prepare, the things to think about, things that we should discuss at the visit. What's new? What has changed from the last visit? This has to do with, can be a new symptom, or maybe some symptom has worsened, but also Maybe we instituted a treatment. We started a medication. How has that worked for you? That's a very important thing for us to know. Did it work a little bit? Did it give you a side effect? Did it not work at all? And then, again, key, what are the 2 or 3 things that are really bothering you the most? What is really interfering with your ability to do your daily activities, to, you want to go out and have lunch with your friends, but this one thing is really interfering with your ability to do that. And not only the symptom, what is it, but also how is it interfering with your life? What is it preventing you from doing? What is your goal? What is it that you want to go out and have lunch with your friends? That's the goal. Okay, so how do we help you do that? Again, like Dr. Golby said, 30 minutes is really not enough time to be able to cover everything that needs to be covered, unfortunately. But really trying to get those things that are going to make the biggest difference in your life, the biggest impact. That's what you want to be thinking about when you come talk to your doctor. And of course, what questions do you have about the condition? We have Dr. Google nowadays, right? Yeah? So we can go online and Google all of our symptoms and find out what kind of treatments. But really, your best bet, you go on the internet and some of these sources are not credible. There's people blogging. You've never heard of this website. How do you know what to believe? So this is something that really is your doctor's job. They really should be educating you. You need to have, you need to feel that you understand what's happening, what's going on. So if you have specific questions that you were Googling last night about, those are the things that you should also be bringing to your doctor's attention. Okay, and then of course, write it down, right? You're coming to the appointment, oh, my car, oh my goodness, I have to go get the oil changed, It's very distracting. You're like, okay, I only have 30 minutes. I have to make this, write it down. It really helps you gather your thoughts and make sure that you're not forgetting some of those key things. And then what to bring, same as the first visit, right? You want to make sure that you're bringing a family member, someone who's close to you to help you remember, to help you process the information. Updated medical list. Always, even if you come to the office and say, it's the same as last time, I guarantee something probably maybe has changed. So it's always good to bring the updated list, take a snapshot on your phone, bring it with you. If there's been any new testing that's been done, a lot of times, unfortunately, our medical system, our electronic medical records are so fancy, they're so great, but they don't talk to each other. So I don't know that you had a CAT scan at this other hospital unless you tell me. Okay, so I wanted to leave time for questions. Happy to talk about anything. Yes?
What do you suggest for when the Botox doesn't work? Dystonia, which my husband experiences every single day when sundowning takes place, it's like, especially that time, and sometimes, so he calls up this, and then he's not able to express anything, tell me what's going on. What do you suggest for that?
So the question is, how do we treat dystonia when the Botox doesn't seem to be working? Mm-hmm. So Botox, all these treatments that we're talking about, they are meant to treat the symptom. They don't treat the underlying disorder, right? And the treatments, none of these treatments take away the symptom. They are all meant to alleviate the symptom, improve the symptom. We don't know how much they will improve until we try. So with every treatment that we institute for these conditions, we want to set an expectation. What is it that what is our goal with doing this intervention, right? Depending on what's causing the dystonia or what's causing the inability to use that part of the body, the Botox addresses things like the muscle tightness, right? It can loosen the muscle tightness. We do things like try to increase the dose, but there is eventually a maximal dose that is safe to give. Again, it's managing expectations. What is it that we're trying to get from this? If we say, well, it didn't reverse the problem, then of course no medication for any condition anywhere in medicine is going to really work, right? But if we're saying we just want to loosen it a little bit to make, for example, transfers a little bit easier, or trying to make it so that getting the shirt on is a little bit easier, or we can clean, inside the elbow area a little bit better, or inside the hand. So Botox still, I would say, is probably the best medication for that particular problem, the dystonia, just how tight the muscles are. But it doesn't reverse the problem.
Right here.
Yeah.
I have a follow-up for the Botox. My husband does get Botox every 10 weeks. I think it's 500 units. Our local neurologist gives it to him. A visit to his movement specialist suggested he get additional and other parts that are beginning to tighten up. What is your recommendation as far as how much he can get?
That's an interesting question. So we used to give a little bit higher doses. 600 is definitely getting up there. And a lot of this isn't really based on not like humans. We didn't inject someone with 2,000 units and see what happened. So we're not allowed to do that apparently. It depends on your insurance company too. And sometimes we do have to really fight them to go above even 400 units. I had that experience recently. I think 600, I personally, again, this is a discussion with your doctor. All these treatments are very individual, and I don't know the whole medical history and all that stuff. So I can't make personal recommendations from up here. But generally, I have definitely seen people tolerate 600 units just fine. Oh.
Okay. What happens if your loved one doesn't recognize the problems that they are having? And so if you go to a doctor appointment and you are telling them the symptoms that you see, and then he gets really defensive, and how do you deal with that?
That is a great question.
How do you give the doctor the information the doctor needs without triggering a whole mess?
So the question is, if the person that you go with to the appointments, your loved one, is affected and is unaware of some of the problems that are happening and denies even when you go to the appointments, how do you convey these things to the doctor, because you know that they need to be intervened on, but you don't want to trigger an episode or yeah, right? So luckily, we are aware that there is, in many cases, there is some cognitive involvement, right? We know that a lot of it can manifest as being actually completely unaware of the deficit. In fact, it can be quite dense, like very severe. We know this. The neurologist knows this. In fact, part of our examination when we're looking at the patient is trying to understand, how aware are you? What even part of our exam is looking at that. One of the reasons that we do like for you to bring someone with you when you come to the appointments is because even early on, I've had the experience where someone walks in and says, I'm great, I don't know why I'm here, but I can see that there's a problem. So having that extra person, having someone else describing, well, this is what a day at home is like, is very helpful. And sometimes even just framing it that way, well, this is what my day was like yesterday. Let's talk about that. I have other people who will write it down and hand it to my medical assistant, who gives it to me before they walk into the appointment. Some people will email me questions separately, so it's very dependent on what works for you, but we are aware that sometimes there is that mismatch, and we do our best to navigate it. Yeah.
Things to bring to the appointment. Everyone today has smartphones that have cameras and can record voices. Would you find it helpful if certain behaviors were caught on the camera, either as a video or as a sound bite? Would that help you in doing your diagnosis, or understanding what the disease was or where the course was?
That's a great question. So if there are, for example, episodes that happen at home or moments where things are really bad and then other times when things are really good, keeping in mind that I see you for 30 minutes in maybe a 6-month cycle of your life, right? So most likely I will not capture everything that you see every day. That is a great point. I often ask people to take a video. If someone comes to the appointment and tells me there's these things happen, I don't know what they are, I don't even know how to describe them really, it's, whatever, I say, okay, record it for me. Try to get a video, bring it in. Again, with all the smartphones, we are so fortunate these days that we can do those things, snap pictures of our medical list, but definitely taking videos of an event is very helpful. And in fact, going back to your question before, if there are things that happen at home and someone's denying it, maybe snapping a video just to show what the situation is can also be very helpful.
So, question about impulsivity and fixation. I'm sure that's part of the cognitive part of it. What is used to help with that?
How do we deal with impulsivity, right? That's a tough one. A lot of it has to do with constant cueing, which we learn through physical therapy and also just with experience. One of the most common impulsive things that we see is people forget that they fall and they get up and try to walk without help. We see that a lot. Sometimes it's enough to just keep reminding, keep cueing. A lot of times we just need more hands on deck. We need someone with eyes on. So it really depends on the particular situation. There's, sometimes I've had the experience where adding some medications for the cognition can be helpful just because it helps people focus. It helps them sort of retain information a little bit better. It doesn't eliminate this problem. So we still will probably need a lot of frequent cueing, frequent reminders, as well as more hands on deck, more eyes on deck. Yeah.
How do you diagnose MSA versus Parkinson's?
I can't remember if so I had a new set of slides, and I had those slides just in case. Okay, but because I saw that somebody had asked those questions. So the diagnosis of MSA and PSP and CBS, the gold standard diagnosis is autopsy, which is just not very convenient when you're in my office, right? I can't prescribe that. But for us to be able to tell someone this is what you have, there is a published set of criteria. There's these check boxes that we have to go through. And if we know that if we get these check boxes, then the likelihood that you have this is pretty high. There have been, with all of these criteria, afterwards, a bunch of people try to test, well, how accurate are these? Looking backwards. We have the brains of people who have passed away, and we know that they have PSP, for example, or MSA. Let's go back to their medical charts and apply these criteria and see how accurate they are. And depending on the study, depending on the situation, and depending on which level of certainty you have. So with these diagnoses, there's usually a lower level of certainty where we call it, possible MSA. We're pretty sure, but it's not a slam dunk, for example. And then there's a higher level where, okay, we're pretty certain at this point. That would be probable MSA. So for possible MSA, for the very first visit, the sensitivity is meaning the sensitivity is pretty good. It's about 75%. It goes much higher towards the end, after you've had it for 10 years or 7 years. But the specificity is not so great early on, but again, gets better as as time goes on. So that really the way we make the diagnosis is really by talking to you, getting your history, and examining you. Sometimes for some of the criteria to get a possible diagnosis, you may need an additional something. a test. Sometimes a brain MRI can add a little more information. Sometimes a PET scan can be helpful. So your doctor will try to determine, okay, do I already have you in this box, or do I need another test to sort of make sure that we know what we're talking about? Does that make sense? So the diagnosis is clinical. What's that? Oh, specifically. Okay, so specifically for, again, I had a slide about this, and I'm sorry, I don't have it. To make a diagnosis of probable MSA, you need, it has to be an adult. It has to be someone who has a progressive something happening to them, and it can either be Parkinsonism or it can be ataxia, the cerebellar ataxia, which is the kind of, I didn't mention this before, Dr. Golby mentioned it, that ataxia is a kind of an unsteady gait, a lot of staggering. Some people describe it as, well, people think I look like I'm drunk. So you have to have one of those two plus symptoms of autonomic dysfunction. And not just symptoms, not just, well, I urinate more frequently than I did before, but you have to have hard evidence of something autonomic happening. That puts you in the probable category.
I'm curious about how quickly you refine the diagnosis. If someone, you're certain or you believe that someone has PSP, do you get into the level of what kind of PSP? Is this Richardson's? Is this Parkinson's? With the patient?
Generally, no. So this information about the different subtypes of PSP is relatively new. It's based on some pathologic data that we have, and now there's some imaging data that's supporting it, just showing that actually different regions of the brain are preferentially involved in different places. We're still learning a little bit about the differences in the natural history of those conditions. So, it is helpful to us to sort of try to understand which category we're looking at. One, because it helps with diagnosis, where we can say, oh yeah, okay, it doesn't look like the PSP that I saw in this other person, but I know it's still the same condition because there's these other subtypes. It also helps us understand kind of what to expect to see in addition, and what we might expect in the future. That being said, for all of the conditions, eventually they do start to look very, very similar, even though they start out a little bit different. So generally we don't discuss that, but if you now know about it and you want to ask your doctor, that's a great question. Yeah.
Doctor, how do you deal with the category of depression and maybe motivation? What do you do?
What do we do for those symptoms? So it depends, always, on the individual. But we treat depression in these conditions very similar to how we treat it in everybody else. A lot of, depression can come because of the underlying condition of the chemical changes that happen in the brain. It can also come because of the situation, right? An adjustment sort of period, or adjustment disorder, as we call it. The combination of medical treatment and psychotherapy is very, very strong. Again, if we think it's more of the chemical side because of the underlying condition, then we're probably going to push a little bit more of the medical. If we think it also has a lot to do with the situation and coping mechanisms, then we're going to push more for the psychotherapy, because again, and it also depends on the level of cognition. How is someone able to process the information? If we're talking about someone who's depressed, but they're thinking very clearly and can really take concepts, then psychotherapy is actually very, very effective. Okay. Thank you very much.